Hey girl, hey. Okay, this is Dr. Tasha Rogers. If you don't know, I'm back. Today we're going to talk about fibroids. I did get the memo, honeys, and we're going to talk about fibroids. Now, before we even get started, I'm going to need you guys, if you're not subscribed, click the subscribe button because the girl drops fire like this all the time. And then I want you to go and like the video in the beginning. Like it in the beginning because y'all watch the whole video. Y'all forget to like the video. I don't ask you for much, but I do need you to like, subscribe, and then share this. If you don't have fibroids, you may have a friend who has them. You may just share it. Make sure we are getting this accurate information out to the peoples. Okay, so please subscribe, like, and share. Drop your comments. Let me know what you think. And then we'll go from there. Okay. Now, I want to make you guys aware of something. Okay. Fibroids are not like, ramen or something like that. Like, it's not one size fits all. Every person's fibroids are unique to them. Where they are, what they're doing, and we'll get a little bit more, and we're going to get a lot bit more into that. But please don't think, oh, tell me about fibroids because my cousin did this for her fibroids, so I'm going to do it for my fibroids. No, that's not how fibroids work, girlies. So let's talk about it. I'm going to take you from the rooter to the tutor. Get a pen, okay? I'm going to hold on, girl. I'm going to hold on. Get a pen, okay? Get some paper because you guys need to understand this. And not only do you need to understand, you need to understand it for yourself. But, when you're having communication with other ladies, and then also when you guys go in and you're having communication with physicians, like, know what you're talking about. And that will help you know if they know what they're talking about. So it's really like a litmus test. Like, the more you understand, when you get a doctor who know what the hell they talking about, you will know. So when we talk about fibroids, fibroids are very interesting in that so many people suffer from them, but so few people seem to truly understand them. And it's not very complex. I'm going to break it down for you. I'm looking for something. Y'all know how visual I am. I'm looking for something that will help me break fibroids down for you. And I think I got it. Don't laugh at me, y'all, okay? No. I don't want y'all clowning me because y'all get real interesting and extra. Okay. Hold on for a minute. Hold on. Okay, y'all. So I had to go to my coffee bar, okay, so that I could be ready and able to be visual with the fibroid explanation when it comes up, okay? So when we talk about fibroids, what we're talking about are benign growths. And when we say growths, like tumors, but not cancerous, they're benign growths, and benign means non-cancerous. And most of them are non-cancerous, only like 1 out of 350 cases. Like 1 out of 350 cases are going to be cancerous. And that is actually way more than it used to be. Interestingly enough, the numbers used to be lower and better than that, but it's 1 out of every 350 is going to be cancerous. The overwhelming majority, and we really do take it when we think fibroids as providers, we generally think benign, which is non-cancerous. But they're tumors, and it has like fibrous tissue and some skeletal muscle in there. But essentially, if you want to kind of visualize what a fibroid feels like gristle. It's like gristle. You know the gristle that's like on the head of a chicken wing? Like the hard part that you kind of just spit out? Gristle. That's what they feel like. For the most part, if I had to best explain them. Now, interestingly enough to you guys, fibroids, the size of your fibroid is not as important as the placement of your fibroid or where they're growing. So just so you all know, because when I have people come in and be like, I had them fibroids on my ovaries. No, you didn't, sis. No, you didn't, sis. No, you didn't now. Now let's talk about, let me get you together. You didn't have no fibroid on your damn ovary, okay? Now, when we talk about fibroids grow on the uterus, and that can be like the body of the uterus, the cervix. Yes, you can have a fibroid on your cervix, but they grow on the uterus. Now, when we talk about fibroids, when I say placement, okay, so I'm visual. right, guys? So let's say this is the inside of the uterus, the inside cavity. I had to go to my coffee bar. Let's say this is the middle of the uterus, the muscle layer. And then let's say that this is the outside layer. So I can't hold all three of them, but we got the middle, the outside, and we got the, hold on. So we got the inside, we got the middle layer, and we have the outside. Okay. When you have fibroids on the inside of the uterus, like the inside the cavity, we call it intramural. Okay. So you can have fibroids on the inside or intramural fibroids. And not really, no, I can't really, okay. So you have fibroids on the inside of the uterus. Those are the fibroids that are mostly going to cause you a lot of bleeding. Anything that alters the inside cavity of the fibroid, inside cavity of the uterus, if it alters the cavity or the lining of the uterus, is going to cause you bleeding. So even if it's like a 1 to 2 centimeter fibroid, like an itty bitty little old something, if it's on the inside of the cavity, you're probably going to have bleeding issues, okay? Anything that's in the wall of the cavity. Now, this is very interesting because you can be on the inside, like that middle part, okay? If you're on the middle part and you poking out inside the cavity, like you're poking inside that cavity, you're going to have bleeding. But if you're in the middle part, like the wall, and you're poking out toward the outside, might not really have any symptoms. So if you got like a 2 centimeter one that's poking on the inside of the cavity, you're probably gonna bleed. If you got an 8 centimeter one that's poking toward the outside or the lining of the not the lining, or the outside part of the uterus, you're probably not gonna have too many symptoms. So uterine fibroids are not about size, they're about where they're located. So I guess that wasn't real good. So if you got 3 layers, you got your inner layer, your middle layer, and your outer layer, right? Anything on that inner layer or that's pressing on that inner layer, you're probably gonna bleed. That middle layer, that wall, if it's in the wall and pressing on it, if it's in the wall and it's pressing outward toward like the saran wrap, it's called the serosa, but I call it the saran wrap of the uterus because it kind of covers the uterus. So that outer layer, probably not too many symptoms, okay? So fibroids are about where they are, not about what size they are, okay? Now, when we talk about symptoms for fibroids, they vary. People are like, I ain't got fibroids, I'm not bleeding. Right, but symptoms vary. So you can have pelvic pain, you can have painful periods, you could have heavy periods, you could have just pressure, like just all the time pelvic pressure, pain with intercourse. You could also have difficulty urinating or difficulty pooping because the fibroid uterus can literally be plunked right on that. So this is a perfect example of somebody who's going to have big fibroids on the outside of their uterus. Well, that uterus is going to be sitting on your colon or sitting on your bladder, and that's going to cause other symptoms. So bleeding is not the do all, end all, be all. Everybody with heavy fibroids does not bleed. I mean, big fibroids, they don't bleed heavy. So bleeding is not your only thing. So it's not to say, well, I don't think I got fibroids because I don't bleed. No, it's other symptoms, it's other things. So just make sure if you have any of these symptoms or something's happening in the pelvis or it doesn't seem right or you have a level of discomfort, it can even present as back pain or knee pain, because what ends up happening sometimes is that uterus can compress the nerve that goes down that back leg called the sciatic nerve, but it can compress that nerve, and then you got pain with the leg, the thigh, the knee, back pain, and it's all due to fibroids. So if there's anything untoward going on, make sure you have a full evaluation, okay? So the symptoms are the symptoms, and the location, just like real estate. When it comes to fibroids, location, girl, okay? Now, people say, well, why did I get that? We don't know. We don't know why. Some people can surmise, oh, it's from milk. Oh, it's from red meat. Oh, it's from, baby. We don't know. We don't know. We know hormonally, hormone makes them grow. We know some progesterone, we know estrogen and progesterone can kind of make them grow, especially estrogen, but we don't know. We don't know why some people get them and some people don't. We think it may be genetic, but at the same time, it's like, well, you generally will grow up in a house with your mom. So was it because you ate the same foods? Was it because you breathed the same air? Was it because you used the same detergent? Or is it truly genetic? We so little that we know about fibroids. We know what will make them worse, and we don't know what makes them start growing, but we sure know what makes them stop growing, and that's menopause. So yeah, one of the only benefits, one of the few benefits of menopause. I can't say the only, but the few benefits. So we can't really tell you that. Oftentimes what I will tell people is, what's the first thing that people ask me when it comes to fibroids? Lifestyle. Now, I always recommend this. Make sure you're drinking alkaline water. Make sure you're getting a good amount of exercise. Make sure you're not eating foods that are inflammatory. And those are processed foods. Those are sugars, fast foods, different things like that. So a lot of people who suffer with fibroids will tend to say, oh, I want to switch to a vegan diet. Well, shout out to my vegans. I have no disrespect for you, but if you're going to just replace meat with carbohydrates, which in most African Americans is going to be worse because there's a high level of insulin resistance in our population. So carbohydrates is awful for you. So if you're just going to replace meats with carbs, you haven't done yourself a favor, like not at all. So anything that's going to be inflammatory, you want to cut that out of your diet. And a lot of times you'll see when people change their diets, they say, oh, my fibroid shrank. It's not that your fibroid shrank because it shrunk or shrank. Anyway, it's not that the fibroids got smaller. Well, in some instances, what happens is the inflammation comes out of your body. It decreases. And just like anything else, just like the inflammation will come out of those fibroids too. And a 5 centimeter one may go to 3 centimeters, or a 6 centimeter one may go to 4 centimeters. And that's just kind of how it works a little bit. So when we're talking about fibroids, lifestyle also plays a huge role in them. But again, there's nothing anybody can tell you to do that's going to prevent you from getting fibroids. Unfortunately, that's just where we are. Now, when we talk about fibroids, the one thing that you have to understand is if somebody says, oh, I have a fibroid, I have to get that taken care of. No, we treat fibroids symptomatically. Does that make sense? So, because should be, I'm gonna say should be for me, and should be anything that you do in medicine, the benefits should outweigh the risks, right? So what does that say? That says if you have fibroids, and they're not bothering you, you're asymptomatic, you're not bleeding heavy, you would never know you had them unless somebody randomly did an ultrasound for something, maybe even totally unrelated, and found out you have fibroids. So it's not like, oh, I got to run to the operating room, or I got to get something done because I have fibroids. No, fibroids are treated symptomatically. I usually tell my patients, I'm going to bother them as much as they bother you. And that's kind of how I deal with fibroids. But again, everything is so specific, because how I deal with fibroids in a 20-year-old woman is different than how I'm going to deal with them in a 40-year-old woman. How I deal with them in somebody who wants children and is childbearing is different than how I'm going to deal with them in somebody who's had 4 or 5 children and they don't want any more children. It's a different beast, because they have different goals, if that makes any sense. And we'll kind of touch on that a little bit more when it comes to treatment, because you always have, this is why being informed is so important, because I want the least invasive thing. I don't want no surgery. And I respect that. But what is your goal? What is your goal? Because you can do a bunch of different stuff, and you're going to get some doctors who are like, okay, and they're not going to sit and offer you and say, hey, listen, let's talk. You can do what you want to do, but let me educate you first. As long as you're educated, then you make the decision that's right for your life. That's what I do. And I'm a surgeon, so I operate kind of, sort of, sometimes, but I operate. So I'm going to counsel you on my procedure, but then I'm going to send you otherwise to get counseled on other procedures, because I want to make sure you get the appropriate counseling. Once you are counseled on all the options that are available to you based on your clinical situation, then you make the choice and what you want to do. And I rock with whatever choice you make. My goal is never to change your mind. My goal is to educate you so you can make the best decision for you, and then we go with that. Now, whatever consequence comes for that, baby, you knew what you were doing. So that is how I move forward and talk to and educate my patients. Now, you say, well, why is it different treatment for 20-something and 40-something? So if I have a 20-something-year-old, then generally that's somebody, and not always, so let me be clear, somebody who is still looking at family planning. They still want to have children. And there are some procedures that you can do that, yeah, you can do them. And they're going to work beautifully, but let's say it's going to decrease your chances of fertility. If it decreases your chances of fertility, then it's like, oh, well, let me go see a fertility specialist. They're not going to want to work with you if you've had these procedures. They're going to be like, no, it's nothing we can do. So in an attempt not to have surgery, in an attempt to be as least invasive as possible, you kind of shot yourself in the foot for your goals. Does that make sense? Now, somebody who's in their 40s who may have decided at this point, I don't want children, or they have had children, or maybe they have had their tubes tied, the world is open to them. They can do any procedure they want, from least invasive to most invasive, because they don't have any goals. Their goal is to stop bleeding. Their goal is to deal with their fibroids. So please know and understand, what someone did does not mean that that is the thing for you, because it worked beautifully for them. Yes, I'm sure it did, but their goals may be different from your goals. So please don't jump on somebody else's treatment plan and think that because they got a particular outcome and you want that outcome, that that procedure is best for you. I hope that makes sense to some of you guys, or any of you guys. So I hope that makes sense. So now when we talk about fibroids, we talked about the fact that they're non-cancerous. We talked about the fact that their location is more important than their size. We talked about the fact that the uterus has 3 layers: the inside layer, a middle layer, which is the muscle layer, and the outside layer, which we call the serosa, but I call the saran wrap, because it kind of helps you visualize it. And anything closest to the inside layer is going to be more problematic when it comes to bleeding. Anything closest to that outside layer of the saran wrap is going to be more symptomatic when it comes to like back pain or difficulty having intercourse or feeling pressure. So, yeah, so let's get into some treatments. And treatments vary. And again, a treatment is going to be based on your goal, right? So, you know, we have treatments as least invasive. Y'all know that red leaf raspberry tea is that girl. Y'all know it is that girl Monday through Sunday, okay? It ain't gonna fix everything now. It ain't gonna fix everything. Because some of y'all, these uteruses be coming in ghetto. Now, that's a joke, not meant to be offensive to anybody, not truly ghetto. But what I'm saying is that, you know, if you have a few small fibroids, then the red leaf raspberry tea is going to work great for you. You cannot have a uterus, and yes, I have seen this. You cannot have a uterus that's all the way up. I mean, the size of an 8-month pregnant woman, and think you're going to drink some tea. No, ma'am. No, ma'am. We passed the tea stage. No, ma'am. This is above us now. It is above the tea now. Like, don't drag that tea. That's disrespectful. Don't do that. We're not doing that. But we got something for you too. Now, I do want, you know, people get so incensed, like, I don't want no hysterectomy. Calm down. Ain't nobody saying nothing about no hysterectomy. Anybody trying to snatch your uterus? It belongs to you. Do what you will with it, sis. Ain't nobody trying to get into all that. Let's talk options, okay? Give me some grace, okay? Back up off the back of my heels, okay? Nobody trying to steal your uterus. Now, when it comes to symptoms, we always look at things as mild, moderate, and severe. Once we kind of get to moderate and severe, that is when we want to get into treatment and do some things. So yes, we have the red leaf raspberry tea. Like I said, y'all know it's that girl. Now, they have a new medication out. When I look at the ingredients, it to me is very much giving birth control pill. But okay, it is an oral medication. You do have to take it every day. It's saying you have to take it the same time every day. I'm going to tell you, it probably wouldn't be on my list of necessary things to, I don't know, but it's out there. I really don't have an opinion about it. I have never prescribed it. It's called Fembry. I had to write this down, y'all, because I didn't want to forget it. But it's MY. Get a pen, sis. I'll hold on. I'll wait. Okay, good. It's MYFEMBRY. BREE. And it's an oral pill. It's supposed to be for heavy bleeding associated with fibroids, and it's something that you're supposed to take every day, I guess, kind of like a birth control pill. I don't know a whole lot about it. Like I said, it's rather new, and I haven't prescribed it, and I really don't speak good or bad on anything that I haven't had a whole lot of experience with. But again, it's very new. I'm sure there may be an audience for it. In the space of, there may be some people who don't want to do any type of procedure or surgery, or may not be in a place to do any type of procedure or surgery. Maybe, you know, where you are with your particular job, you want to go in real hard and get you a good hard year of, you know, hard work and good reputation, and surgery just ain't in the plans for you right now, or a procedure just ain't in the plans for you right now. This medication may be awesome for you. So, you know, everything has its audience. So please I don't want that. Just look into it, you know, investigate, you know, see what your thoughts are, and present it to whoever your provider is to say, hey, what do you think about my Fembry? You know, I understand that there's an oral pill that's for bleeding associated with fibroids. What do you think about it? And see what their thoughts are. Okay. And again, it's relatively new. They may or may not know anything about it. Okay. Now, I do want to talk about another medication before I move on to procedures. Now, there is, or two more medications really. There's another medication called, it's called Linzagolix. We used to call it Lupron back in the day, honey. But, you know, they call it Linzagolix. It's what we call a GnRH agonist. And what that is it is a medication, and it's a temporary medication. Let me say that. And when I say temporary, I mean it is not meant for the treatment. It's meant for the management. And so what does that actually mean? So it is a medication that you take. It is an injection. And with this, actually, this one is oral. So Lupron was back in the day, and Lupron was the injection, but this is the oral, but they work the same way. Okay. So that's the new part about it. It's oral, whereas Lupron was the injection. And so what this does is it decreases the size of your fibroids and it decreases your symptoms. But so you're like, oh, that's that girl. That's what I'm looking for. But we generally take it for being temporary, and I'll tell you why, but it throws you into a medical menopause, girl. So yes, you will have the hot flashes, the decreased libido, the dry cooch. You're going to have all that, all of it. You say, well, why would anybody want that? Like, who would choose? I'd rather bleed. Like, who would choose that? Well, oftentimes we'll do this particular medication, or this class of medication, if you're going to have surgery. So let's say you have 10 centimeter fibroids, or you have fibroids the size of a plum, or fibroids the size of a grapefruit, and you might have 2 or 3 of those. Well, obviously, when we get in there for surgery, it's a little bit more trying, because 1, you're going to bleed a little bit more, and 2, those fibroids stretch out the architecture of your muscle. So it's like, by the time we remove those fibroids, sometimes you're really not left with a whole lot of functional uterus. So what we learned over the years is let's try and shrink those down, and usually over 2 to 3 months, you know, we shrink those fibroids down. So instead of a 10 centimeter, now we're removing a 6 centimeter or 5 centimeter. Instead of a, 8 centimeter, now it's a 3 or 4 centimeter. And so therefore it leaves more functional uterus for you after surgery. But let's say you were like, no, I'm gonna just take the medicine and I don't care about being in menopause. As soon as you stop the medication, the fibroids are going to grow back to the size that they were, and the symptoms are gonna recur. Okay, so it is a temporary fix, or a temporary kind of decrease, so that we can decrease the amount of bleeding and possibly, increase the outcome of the uterine surgery. Because we can go and get all the fibroids out, but that may leave you with no functional uterus, meaning your uterus is there, but the muscle is so stretched out, it's so damaged from all the surgery that had to be done. The likelihood of it functioning and carrying a pregnancy are slim. So we try and minimize or mitigate that. So that is the Linzagolix. So Linzagolix. And so that's like an oral Lupron, or an oral GnRH agonist. The injectable GnRH is Lupron. Lupron was very difficult to get approved for. Lupron was very difficult in that the doctor had to give it. It was a couple of months. You had to send all this paperwork in. You had to keep sending paperwork in. Child, Lupron was a pain in the behind. You hear me? But it was all we had at the time, and it did what it needed to do as far as the same thing as the Lingolics, just shrinking down the fibroids in preparation for surgery to give you possibly the best absolute outcome. Okay, so there's that. And then we have TXA, which I cannot say this word, I hate it. Let me focus. Tranexamic acid. And so tranexamic acid, not only just for fibroids, I use it for patients who have super heavy periods while we're trying to figure out our plan as to what we're gonna do. But it's 2 pills for breakfast, 2 pills for lunch, and 2 pills for dinner. You only take it during your cycle. So like day 1 is 2, 2, 2. So it's 6 pills a day basically, and it decreases your bleeding by 70 to 80%. So it certainly works, and it's something that you only have to take during your cycle. But again, I'm very solution based. Like, let's not keep treating the problem. Let's kind of fix it. Like, let's fix it. Let's fix it, sis. So again, for me, in my mind, TXA is temporary because it's like we can fix you immediately. This is not anything you have to wait for. It doesn't wait to kick in. As soon as you start taking it that day, you see a decrease in the blood, right? So TXA can be a godsend, you know, a lot of times, especially as people come in and they're like, I'm bleeding out, you know, I'm changing more than a pad an hour, because that's heavy bleeding. If you have to change a soaked pad, if your pad is soaked more than once an hour, that's too much bleeding, okay? And so, you know, you can easily kind of get control of that with TXA. So I love that. We also use it for like hemorrhage in hospitals, you know, postpartum and different things, different reasons you may be hemorrhaging, vaginal hemorrhaging. We use TXA. Okay, so I'm all for TXA. Now, the next thing, and y'all got to give me some grace with this because I feel y'all about to kick up dust like right in my eyes and punch me in the back of my head when I say this, but please don't. It's an IUD. Now, I'm a lover of IUDs. I'm gonna let you know right now, but I'm anal as hell too. So let's talk about that. When we talk about IUDs, people are like, oh no, I want the non-hormonal one. I want the non-hormonal one. Well, based on what your thoughts are, all of them are non-hormonal. You say, what does that mean? When you have an IUD, there is no hormone circulating in your bloodstream at all if it's placed properly. No hormone circulating in your bloodstream at all. The only hormone is on the lining. Remember we talked about that inside of that uterus with that bleeding? Yes, the only hormone, and this progesterone only, it is on the lining of your womb. That's why placement is so important. If it's placed too far in, it's going to be in the muscle, and then you're going to start to have symptoms because it's now going into your bloodstream. But it should be sitting in your uterus, not in the muscle, just sitting on the inside, and then it thins out your lining. So not only is an IUD indicated for pregnancy prevention, it is also indicated for heavy bleeding. And that's why, because it thins out that lining. Now that copper IUD, girl, you're going to bleed heavy and you're going to bleed long. But listen, I listen, I don't judge. Some people are so super attached to their period because when you have an IUD, either your period is going to be 70 to 80% lighter or you won't have it at all. So you get some people get a super light period after having a heavy period. Some people who spot, some people who get nothing. I don't know who you're going to be. Am I going to get my period, girl? I don't know. Let's wait and see. I have no idea. And there's no way of telling until it's in. But with that copper IUD, baby, that Paragard, baby, you gonna bleed. You gonna bleed for the full time you on your period, and she's gonna get heavy. Nobody told you that. Let me be the first one to be like, oh, that's why I'm bleeding. Yes, it is. Yes, it is. So even me for ultrasound, for IUD, I've done thousands. I don't care. The human body is a very interesting thing. Everybody's body is different, okay? So when it comes to IUDs, I ultrasound. If it's just too difficult in the office and my hands and my mind and everything ain't jiving, we're done. And I'm gonna put it in under ultrasound guidance. Some I just kind of am able to get in, boop, boop, and then I'm still gonna do an ultrasound to check, to make sure that it's in the proper place. Once it's in the proper place, it ain't gonna move, it ain't going into your bladder, it ain't going into your bowel. The worst thing it'll absolutely do is fall out. But it's not going to travel anywhere because it's where it's supposed to be. When you get all these traveling IUDs, they're going to hit, it was placed wrong in the very beginning, and it's looking for its sweet spot. It's looking for that just space that it's supposed to be in. So no, the IUD is not the problem. Low key, it be the providers that be the problem. not even low key, high key. So for me, and you can probably even request this, be like, hey, you put my IUD in, can I get an ultrasound just to make sure it's where it's supposed to be? And and also when it comes to picking an IUD, the provider has to pick right. Don't pick which rep comes to the office and brings you the best lunch. Like, pick the best IUD. Like for me, when I decide based on how many children you've had, or if you've had children, or how long ago you've had children. And the reason for that is the size of the IUD. You get some IUD, the Mirena, the Liletta, and the Paragard. Okay, there are what we call normal size, like this big, like. But the Skyla and the Kylena are a little bit smaller. So I will reserve the Skyla, and the Skyla is 3 years. It only lasts for 3 years. Now you can pull an IUD out at any time you want to, sis. But the Skyla lasts for up to 3 years. So I'll usually do that for somebody who's like, oh, I might have a baby next year, or maybe the year after, but definitely within the next year or two. Okay, you're going to get a Skyla. Okay. Now, the Kylena is for somebody who's never had children, not never had children, who has a smaller uterus, maybe never had children, maybe it's not sure if they want any. They definitely want more than 5 years because it lasts for up to 5 years. I'm going to throw that in her. I also will throw it in somebody who may have not had a child in 15 years, 20 years, and she has a smaller size uterus. It's just going to be more comfortable, and it's not going to touch every part of the uterus. So I may use that in her. Somebody who's had 3 or 4 children, their youngest might be 9 or 10 or 3 or 4 or whatever the case may be. That's somebody who I'm going to give a Mirena or a Liletta to. So, you have to also pick the proper patient. You can't just throw the same IUD in everybody. A lot of like agencies, like health centers or health departments, are funded, and so they get one type of IUD, and then they throw that in somebody. The person had an awful experience, and then they're like, IUDs are horrible, and they're telling everybody IUDs are horrible. No, your experience with that particular provider with that particular IUD was horrible. So, but an IUD, its job is to thin out the lining. So for anything that's kind of like creating a little bit of a disruption inside of the cavity, the IUD can sometimes combat a lot of that. Okay. So now if you like, nope, I don't want no implants up in me, I don't want none of that. Now we got to go to procedures. And interesting enough, there are more procedures for fibroids than surgeries. But again, it depends on what your goal is, right? Okay, cool. So one of the procedures that, let's hit on this procedure right quick. It's really interesting because, okay, so one of the procedures is called an MRFUS. And I believe that's the assessor. I'm not exactly sure, but it's the MRFUS, right? And it's called magnetic resonance. And it is, it's like frequency ultrasound. Anyway, let me tell you what it does. It's the MR-FUS, okay? And so what it does is it uses ultrasound waves. It uses ultrasound waves by way of MRI. So you get an MRI, and then it shows like where the fibroids are, and it uses ultrasound waves. So MRI is no radiation, and ultrasound is no radiation, okay? And it uses those ultrasound waves, and it goes and it destroys the fibroid. It's directed. Those ultrasound waves are directed to the fibroid. Yeah, I know my nails look good. Shout out to Sylvie, baby. But anyway, it uses those ultrasound waves to destroy the fibroid. And that's called MRFUS. Okay, no cutting required. Then we have something called a radio frequency ablation. Okay, now because we got a couple of different types of ablation we're going to talk about, honey. So the radio frequency ablation, it actually uses heat to destroy the ultrasound. Again, these are procedures. So often you get them done in interventional radiology department, where they can kind of use a machine and they see where the blood vessels are, they see where the fibroids are, and they get all up in there. But with this one, they use a little thin probe, and the probe is probably about the size of like the diameter of like a coffee stirrer. And they get that, they kind of poke that probe into the fibroid, and they poke it in, and it generates heat, and that heat melts and destroys the fibroid. Okay, and that's called an RFA, or radio frequency ablation. You got it? Okay. So again, we have more procedures to deal with fibroids in this day and age than surgeries. All right. So I'm sure you already learned something with those two procedures, sis. Now we have two of my favorites. One of my favorite people in the world does these two: uterine artery embolization and uterine fibroid embolization. We'll get out to that. We'll get, into that. Shout out to Dr. Kevin Carson. He's amazing. He's very sweet. He's very understanding, very mild-mannered, doesn't make you feel bullied. He makes you feel heard. And honey, when he does these procedures, he gives you his cell phone number. Like, don't be out there roaming and trying to get it figured out and whether this is normal and that's normal after the procedure. No, ma'am, just go ahead and call my cell phone. Like, he's one of those. So he's a great guy. But anyway, so uterine artery embolization. Now, with the uterine artery embolization, again, you get an MRI, and you're actually on what we call a fluoro machine. So you're on a table. The table moves like, and you're literally under and like an X-ray kind of, if you want to think about it, machine, and it literally maps out the blood vessels to your fibroids. So they go into the blood vessel, your joint, your groin joint. And they go into like their femoral, the femoral artery, and that they guide up. It's like a little guide wire, and it guides up into that like blood vessel of the fibroid, and it blocks off the blood vessels to the fibroid. So the fibroids no longer have blood vessels, and they kind of shrink, they get hard, and they die. They turn into little inactive rocks. Okay, and they do that. And again, it depends on whether you're a candidate. Please don't go up in them folk place with 15,000 itty bitty little 2 centimeter fibroids. Like, I want to deal with this. Girl, no, ain't nobody doing that. You need another procedure. But and it tends to work very well. Now, something that a lot of people won't tell you, and Carson will, but once you have a uterine fibroid embolization, is it possible for fibroids to grow back? Yes. Not the same fibroid, not in the same spot, but if it's another spot, yeah, another fibroid can grow. Like, they do. There's no procedure that's going to prevent fibroids from, no, they can grow back. It's always a chance, okay? So just be well aware of that. And understand, when you have the uterine fibroid embolization, this is one of the procedures that, sometimes reproductive endocrinologists or infertility specialists will not want to do, like in vitro and things like that if you've had this procedure done. So this is why I'm like, this is one of those procedures where a lady in her 20s may not want to necessarily do this, because you don't know where life is going to end you. You don't know whether you're going to have kids or not. You're going to know if you have kids, and this is one of the things that are going to limit the possibility of in vitro fertilization. And again, I'm not going to speak too deeply on it because it's not what I do, and I don't like to counsel too much on it because I might be wrong with some of the numbers and statistics, but the information is on point. Now, there's also another ablation. It's a uterine artery ablation, or embolization rather. So uterine artery, and neither one of them is an ablation. So you got a uterine fibroid embolization, or a UFE, and then a uterine artery embolization, which is a UAE. Totally different. So a uterine artery embolization, this is for people who may have adenomyosis. And I'll talk to you a little bit about what that is. That's when that middle lining, and we keep talking about that inside layer, when that inside layer and the outside layer, they're just supposed to touch like this. All the layers touch. But when that inside layer grows into that muscle layer, you get all kinds of painful periods, the bleeding, heavy bleeding. And if you do try to do like a burning of the lining, it's not going to work because the lining has grown into the wall. So if you do a uterine artery embolization, it basically blocks off the uterine artery, which is 80% blood supply to the uterus. So no, the uterus doesn't die because it gets blood supply from like little vessels everywhere. And so it still thrives, but the main blood vessel to the uterus is blocked off. So if you have a lot of fibroids, if you have adenomyosis, if you just simply have heavy bleeding, a uterine artery embolization, when we're trying to cover more area versus just spot fibroids, a uterine artery embolization is generally going to be the way to go. But again, everybody's situation is different. You need to have an ultrasound, an MRI. You need to have somebody sit and specifically look at your stuff and tell you, based on where your fibroids are, what size your fibroids are, what your goals in life are, what procedure is right for you. Don't be trying to piecemeal it and put it all together, and you're going to go in the wrong doctor's office and be like, I want this procedure. They're going to be like, okay, with no counseling, and then 5-7 years later, you done shot yourself in the foot. So please make sure you know somebody who knows what they're doing, understands this whole process, is willing to explain it to you, not based on how much money they're going to make, but based off of your goals and what's going to be the best thing for you and what you can or should do. The one thing that I would recommend, guys, is, a lot of people are like, I'm not doing nothing about these fibroids. I'm not doing nothing. I'm going to just wait. I'm going to just wait. I'm going to just wait. And sometimes you wait until the only option that you do have is surgical. When we talk about surgery, there are three different things that we can, three different things, but different types. So if you have fibroids on the inside of that cavity, keep talking about that inside, because that's that bleeding. Sometimes based on, you can go in and do what we call a hysteroscopic myomectomy. And the word myomectomy means removal of fibroid. That's what a myomectomy is. Anytime somebody hear ectomy, they swear it's a hysterectomy. No, it's a myomectomy, and that's removal of your fibroids. But sometimes if it's on the inside of the cavity, we can go through the vagina and we kind of shave them down. We just shave them down the inside of that cavity. Might they come back? They might. But again, for a period of time until they do come back, and they may not, it is going to increase your chances of a successful pregnancy, as well as decrease all this bleeding that we're doing. So sometimes you can just do a same day, in the hospital, same day, go through the vagina and just shave those fibroids down. Just shave, okay? Now, the next thing we can do is called a myomectomy. Now, a myomectomy it can be robotic, it can be laparoscopic, or it can be open. It depends, again, on your situation, who you are and what your goals are, what your belly looks like. Have you had surgery before? There are so many things that play into it. So again, there's no set rule, and what type you are going to be best suited for is going to be based on you and what you and your doctor or your provider decide, okay? But a myomectomy essentially is going in and removing those fibroids and sewing up the uterus because it leaves like big divots. Sometimes we have to it can be a mess. And a myomectomy is not an easy surgery. It takes a lot of patience. You have to, I don't like bleeding. When I see bleeding, because bleeding is one of those things, once it gets in front of you, you got a problem. So I don't like bleeding. So myomectomy is not my jam. I'd be like, because a lot of times what we do is we get all the fibroids out and then we close the uterus at one time. I don't want to do that. I want to get the fibroid out and I'm going to close it up because I don't want to, no bleeding. Nope, no. But I got to do what I got to do. I got to do what is supposed to be done. So I hate doing myomectomies, to be honest. But so yeah, you kind of get everything out. But one thing to know is once you've had a myomectomy, you are strongly discouraged from having, and please do not have a vaginal delivery. You have to have a cesarean section, okay? Because anywhere that uterus was cut, it's now weak. So with you contracting and doing the labor thing, you have a chance at a very, 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 not even chance, a very high likelihood at rupturing that uterus. So if we've had a myomectomy, girl, it's a wrap. We're going for C-section. So if they tend not to tell you that, let me be the one to tell you, okay? And then if all else fails, none of the procedures are going to be work for you. It's just gotten too far gone, or whatever the case may be, or even we're suspicious that there might be a cancer, or whatever the case may be. If hysterectomy is your last resort, please trust and believe. I don't know, I can speak for, but back in the day, there may have been some conspiracy theorist stuff and whatever the case may be, but nobody is, out in these streets just looking for your uterus and trying to take it. No, we don't really do any research on it unless you're a part of some type of clinical trial or research study, which you would know have been compensated and would have signed paperwork for. But for the most part, to be perfectly honest, once we send your uterus to pathology, just to, if we take it out, we this is kind of coarse way of saying it, but what they really do is kind of chop it up and put it under the microscope to make sure there's no cancer, there's no lingering cancer, there's nothing we didn't know about. Once we kind of have gotten the pathology on your uterus and you get the all clear, baby, that thing goes in the trash or whatever it is they do, burn. I don't know what they do with it, but it's disposed of, okay? So that is a thing. So if you've taken nothing from this, please don't think that there is a generic or there's an all-around way to deal with fibroids, because it isn't. It's so many factors that play into how we deal with fibroids. And so again, I hope this helps somebody. I hope this blessed somebody. If nothing else, please take notes and try and do a little bit of reading and understanding. So if you do go to speak with a specialist or your gynecologist or whatever the case may be, at least you kind of understand a little bit about fibroids in general and can have an intelligent conversation about it. And then you'll kind of know a little bit if they don't know what they're talking about, because you're gonna be like, well, wait a minute, what about this procedure? Oh yeah. Red flag. So with all that in mind, good girlfriends, that's gonna be it for me today with fibroids. I hope you all learned something, and I hope this benefited you in a major way. Have an amazing evening, y'all. Bye.